Hello, welcome to this clinical educations channel. I'm Boon Singh. Today I'll be talking about the examinations of central nervous system, specifically cater for undergraduate medical students in their internal medicine rotations. So this mini lecture has two learning outcomes. Number one is to remember and describe the sequential steps in performing a central nervous system examinations. Number two is to understand the mechanistic basis of a neurology examinations. Before I further into this mini lecture, it will be very important to recall your prior knowledge on the neuroanatomy of central nervous system, specifically on the cerebral cortex, subcortical gray matter such as thalamus and basal ganglia, cerebellum, brainstem, and spinal cord. Now here is the overview of the examinations of the central nervous system. There are 5 approaches to this exam. Number 1 is to check the higher cortical functions. Number 2 is the examinations of any abnormal movement. Number 3 is a cranial nerve examinations. Number 4 and number 5 is the examinations of upper and lower limb respectively. The assessment of higher cortical functions begin by checking patients' alertness, asking about their education level and handedness. Next, you would examine the patient's orientations to time and place. You would use a 5-point score for orientations to time, ask about year, month, date, day, and time. For orientation to place, ask about the country, state, building levels, the ward or room number. Next, you will assess patients' short-term memory by asking them to register 3 objects. And afterward, you will check the patient's attentions and calculations, and this could be done by asking the patients to do 100 minus 7 5 times, or 20 minus 3 5 times, or the word world, W-O-R-L-D, spelled backward. After this, you will assess for delay recall by asking the patients to repeat the 3 objects that you have asked the patients to remember previously. Next, you will check the patient's language first by naming. Ask them to state the name of the object on your hand, such as pen, watch, or mobile phone. Language could be assessed by checking patients' repetitions by asking them to say no, ifs, ands, or buts, or in Malay, tak mungkin dan cukup mustahil. Language can be assessed by seeing patients the ability to follow a 3-step command. You should not offer a visual cue. Ask them to take the paper from your hand, fold into half, and put on the table. Then, you should assess the patient's reading comprehensions. You will write a written instructions such as close your eye and to ask the patients to follow the written commands. Lastly, you should ask the patients to write a complete sentence. It should have an object and a subject and an appropriate words. Lastly, to end the assessment of the higher cortical functions, you will ask the patients to copy 2 overlap pentagon, and this is to check the non-dominant hemisphere function. So the second part of the examinations of the central nervous system is the assessment of the abnormal movement. And commonly encountered problems in this section will be bradykinesia, tremor, or ataxia. The first problem that commonly encountered in the assessment of abnormal movement is bradykinesia, which means slowness in movement. If patients having a slowness in movement, you should look for Parkinsonisms. On inspections, you should look for paucity of facial expressions, commonly known as mask-like faces, reduced blinking, hypophonia, which means the patients speak very softly, tail-lowering resting tremor. Look for dyskinesia, which could be treatment-related. And when you ask the patients to walk, there will be a slow rising from chair, and the patients with Parkinson's disease commonly walk with a narrow base gait, and they may be shuffling and having a reduced arm swing. Next, you should check for tone. There will be a cogwheeling, and there's a lid pipe rigidity. To demonstrate bradykinesia, you would ask the patients to do a repetitive maneuver, focusing on the amplitude and the speed of the movement. You could ask them to tap their index finger and thumb repetitively, open and close their fists repetitively, pronate and supinate the forearm, or tapping both feet on the floor. So the second problem in the assessment of abnormal movement is tremor, which is a repetitive movement of varying speed. If a patient has tremor, you should look for ataxia and Parkinsonism. You should note whether the tremor occurs at rest, which is a resting tremor. The differential diagnosis would be patients with Parkinsonism, or the tremor occurs at certain posture. It will be a postural tremor. Example would be enhanced physiologic tremor, or tremor occurs with movement, which is a kinetic tremor, commonly seen in cerebellar ataxia. Here are specific maneuvers that you can perform for each tremor. For resting tremor, mental activity actually worsens it. You could ask the patients to do 100 minus 7 in their mind and observe the worsening of the resting tremor. Or alternatively, voluntary movement would suppress the resting tremor of Parkinsonism. Usually you will ask the patients to tap their hand and you can see the resting tremor actually improve. You can put a piece of the paper on the hand to visualize fine amplitude tremor of the postural tremor. You would do a finger nose test, heel shin test to visualize the intentional component of a kinetic tremor. So the last problem of abnormal movement is ataxia. And if a patient is having ataxia, you should look specifically for a cerebellar sign. Note that whether it is a unilateral or bilateral abnormalities, or whether it is confined to the truncal or extremities. On inspections, you should check for titubations, which is tremor of the head and neck. Nystagmus, specifically in cerebellar abnormalities, it should be gaze evoked. We should look for broken pursuit, scanning or staccato speech, hypotonia, and check for dysmetria or intention tremor. We should assess for dysdiadocal kinesia on rapid alternating movement of the hand or the feet, and check for dysrhythmokinesia by asking the patients to tap their hand or feet. And you should walk the patients to look for a broad base gait. After the assessment of higher cortical functions and abnormal movement, we have come to the third component of the examinations of the central nervous system, which is the cranial nerve examinations. There are 12 pairs of cranial nerve. For cranial nerve 1, the olfactory nerve, you would ask the patients, could you smell your meal just now, or offer some sample of common flavors such as coffee, orange, banana, or vanilla, and ask the patients to name the flavor. For cranial nerve 2, the optic nerve, you should start by assessing the patient's visual acuity with aided visions using a Snellen chart. Next, you will check the color vision using the Ishihara chart. Following that, you will assess the pupils by checking the direct and consensual pupillary reflex. You should note whether there is a relative afferent pupillary defects. And lastly, you should check for accommodations. The response should be both eyes will be adducted and the pupil will be constricted. Next, you will check the visual field by confrontation, and you will end by checking the fundoscopy. Next, we would usually examine the cranial nerve 3, 4, and 6 together, which are the oculomotor, trochlear, and the abducens nerve. To assess this nerve function, you should note the resting positions of both eyes. You can do so by compare the light reflections from both cornea to look for misalignment, and this test is known as the Hirschberg test. Following that, you should perform a H test. In this test, you will look for diplopia and also the impaired extraocular muscle movement. If there is a double vision, you should cover one eye at one time to determine whether the pathology is monoocular or binocular, and to identify the abnormality, the site of the abnormalities. So the subsequent part of the cranial nerve examinations is the examinations of the cranial nerve 5, which is the trigeminal nerve. It has both motor and sensory component. For the motor component, it is basically the assessment of the muscle of mastications. For masseter muscle, you should instruct the patients to clench their teeth and palpate both masseter to check for tone and muscle bulk. And you can ask the patients to open their mouth and resist your hand from closing it. Abnormal response will be deviations to either side if there is a pterygoid muscle weakness. You should perform a jaw jerk, which can be exacerbated in an upper motor neuron lesion above the foramen of magnum. Next, the assessment of the sensory component of a trigeminal nerve. You should use a light touch or pinprick to area innervated by ophthalmic, maxillary, and mandibular branches of a trigeminal nerve. In each area, you should test both medial and lateral aspect to detect onion pattern sensory loss in syringobulbar. You should end the examinations of the sensory component of the trigeminal nerve by request to perform a corneal reflex, which the efferent of the corneal reflex is innervated by the cranial nerve 5 and the efferent nerve is cranial nerve 7. To do so, you can perform a light touch using a cotton whisk on the cornea to produce a blink response. The next cranial nerve would be the 7th cranial nerve, the facial nerve. It has both motor and sensory component. The sensory component is difficult to test in the exam setting. To check for the motor component, you will start by inspections to look for facial asymmetry, the loss of nasolabial fold. The involvement of the lower part of the face only indicate an upper motor neuron lesions opposite from the site of the weakness. Next, to check the frontalis, you would instruct the patients to raise their eyebrow and you would resist them. To check orbicularis oculi, you should instruct the patients to squeeze their eye tightly. If the eyelashes are visible after this instruction, it may indicate weakness. To check for bassinator and orbicularis oculi, you would instruct the patients to puff their cheek. The 8th cranial nerve is the vestibulocochlear nerve that innervates special sense of hearing and balance. To assess the hearing, you would whisper a set of numbers to each ear and ask the patients to repeat those numbers. Or you can rub your fingers on each ear and ask the patients to indicate whether they hear the rustling noise of the rubbing. Alternatively, you could use a 512 Hz tuning fork to perform a Weber and Riley test. In Weber test, normally the patients will hear the ringing equally in both ears. Abnormal response is the revitalizations of the ringing to one ear. In Riley test, we are actually compare the air and bone conductions. The normal response, air conduction should be better than bone conductions, which means the patients hear the ringing louder when the tuning fork is placed in front of the ear than when the tuning fork is placed on the mastoid process. The second component of the 8th cranial nerve is balance. You could assess this by performing a vestibulo-ocular reflex with a head impulse test. In head impulse test, you would ask the patients to fixate onto an object and then you would quickly move their head horizontally for 20 degrees and you should look for any corrective eye movement which is abnormal. The next 2 cranial nerves are cranial nerve 9, the glossopharyngeal nerve, and cranial nerve 10, the vagus nerve. To assess the sensory component of the cranial nerve 9, you will perform a gag reflex to both pharynx. It is because the efferent component of this reflex is innervated by cranial nerve 9 and the efferent component of this reflex is by cranial nerve 10. To assess the motor component of vagus nerve, you could ask the patients to say R and look for uvular deviations away from the site of weakness. The last 2 cranial nerves have motor components only. The 11th cranial nerve, the spinal accessory nerve, innervates trapezius and sternocleidoid mastoid muscles. To assess the strength of trapezius muscles, you should ask them to shrug their shoulders and don't let you push down. To assess the SCM, you should ask them to turn their head against your hand. Abnormal response would indicate weakness of the contralateral SCM. To check for the 12th cranial nerve, which is the hypoglossal nerve, you would ask the patients to open their mouth and you should look for any atrophy of fasciculations of the tongue. Then you will ask the patients to stick up their tongue to look for tongue deviations towards the site of the palsy, and any weakness would indicate ipsilateral 12 nerve palsy.
Now we have completed the assessment of higher cortical functions, abnormal movement, and cranial nerves. The last two sections will be on the examinations of upper and lower limbs. Strictly speaking, they are not really a central nervous system examinations, but a neurological examinations, because it can detect both abnormalities in the central nervous system and also the peripheral nervous system. As you can see, examinations of upper limb would localize abnormalities to long tract of the spinal cord, anterior horn cell, roots, spinal nerve, plexus, peripheral nerve, neuromuscular junctions, and muscles. To examine the upper limb, you should position the patient in sitting or lying the patient down at 45 degrees on an examination couch. The exposure should include both shoulders, scapula, arm, and forearm. You should start by inspecting the patients. A gross screening, you should detect the facial asymmetry, any gaze preference, speech abnormalities, check for pronated drift, look for muscle atrophy or wasting, whether there's a contracture or scar of tendon release, limb atrophy, fasciculations on the upper limb, specifically polyhedral signs, winging of scapula, whether there's any tremor, resting or positional, whether the patient is using any assistive device. Next, you will examine the tone of the upper limb. You should check both sides and compare each joint sequentially with varied speed and amplitude. To check the power in the upper limb, you should check for shoulder abductions, elbow flexions, elbow extensions, wrist flexions and extensions, finger flexions, and finger abductions. The corresponding myotomes are written at the side of the muscles group. You should additionally check for thumb abductions and appositions, which is innervated by the median nerve, and finger extensions innervated by radial nerve, and thumb adductions innervated by ulnar nerve. Next, you would examine the muscle stretch reflex at biceps, brachioradialis, and triceps. And of course, you should compare both left and right at each level. Having completed the examinations of tone, power, and reflexes, you should proceed with sensations examinations. To check for pinprick, you would use a neuro tip. To check for fine touch, you would use a whips of a cotton buds. Examination should be at the shoulder area, regimen patch area, lateral arm, forearm, and thumb, middle finger, little finger, and medial forearm and arm. The corresponding dermatomes is stated. Next, you would complete the sensations examinations by checking the vibrations and proprioceptions. To check for vibrations, you should use 126 Hz tuning forks. To check for proprioceptions, you should first demonstrate to patients each joint movement before testing them individually. Of course, you will compare both examinations left and right. You should start distally and move proximally if there's a sensory deficit. And both examinations of vibration and proprioception should be done at a joint. The last sections of this lecture will be the examinations of the lower limb. Of course, this is the examinations of both central and peripheral nervous system as explained previously. You should position the patient lying flat on an examination couch. The exposure should make the thigh visible. The aim is to detect upper or lower motor neuron abnormalities. You would localize the lesions to the long tract in the spinal cord, the anterior horn cell, roots, spinal nerve, plexus, peripheral nerve, neuromuscular junctions, or muscles. You should start by inspecting the patients, look for facial asymmetry, gaze preferences, speech abnormalities, muscle wasting or atrophy, fasciculations, limb atrophy, contracture or scar of tendon release, whether the patient is using a wheelchair or walking stick, whether there's muscle pseudohypertrophy, whether the lower limb looks like an inverted champagne bottle, whether there's clawing of toe, pes cavus, trophic changes of diabetes, neuropathic arterial venous ulcer, or any callosity. After inspecting the lower limb, you should examine the tone of the lower limb comparing left and right at each joint sequentially with varied speed and amplitude. Next, the power examination will focus at hip flexions, knee extension, knee flexion, ankle dorsiflexion, great toe extension, and ankle plantar flexion. The corresponding myotomes is stated beside the muscle group. The third motor components of lower limb examinations comprises of muscle stretch reflexes to be checked at patellar reflex, commonly known as knee jerk, ankle reflex, and plantar reflex, which can differentiate between upper motor neuron and lower motor neuron lesions. Having completed the motor examinations, you would proceed with checking the sensations. Checking pinprick with neurotip, checking fine touch with whips of cotton buds, examine at the anterior thigh, knee, medial leg, lateral leg, first web space, which is innervated by deep peroneal nerve, and the sole. The corresponding dermatomes is stated beside the examinations area. Lastly, you would examine the vibrations and proprioceptions at the joints of the lower limb. To check for vibrations, you should use a 126 Hz tuning fork. To check for proprioceptions, first you would demonstrate to patients the movement of each joint before testing them individually. You should compare both left and right for proprioceptions and vibration, and start distally and move proximally if there is a deficit. Here are the references that I used when preparing for this mini lecture. Now we have come to the end of this rather extensive mini lecture on the examinations of the central nervous system. We have covered the assessment of higher mental status, examinations of abnormal movement. The assessment of cranial nerve, upper and lower limb neurology is strictly not only for central nervous system, but also involve the peripheral nervous system. Question and answers, please leave in the comment section. And I hope you have enjoyed this lecture and see you next time. Bye bye.